So, good morning to everybody, and good Sunday. And we started this day of stent failure issues with the first session that is about stent failures. And Professor Vasiliev will be here in a flexible time, 10 to 20 minutes, depending on his mood. And we can start the session. The first speaker is a very well-known Professor Louvard, and he will speak about incident predicting factors, model of stent failure before and after the DS invention. Please, if.
Okay, good morning. So this is a relatively complex themes, and especially you will have only some flash of before DS because this is so long time ago. So mode of stent failure. The principal ones are stent thrombosis, which is probably the more actual now, stent restenosis, and maybe older stent fracture, stent distortion, which can be avoided quite easily, and multiple others like infection. It exists in a long time ago. Stent thrombosis. These are the definition of the academic research consortium for classification of stent thrombosis, and you all know that. The early during the first 24 hours, and late from the end of the first month, and very late after 1 year. And it can be definite for stent thrombosis if you have a coronary angiography or an autopsy, and if for coronary angiography, if it's added some clinical and paraclinical event like biomarker elevation, ischemic electrocardiogram change, and acute ischemic symptoms. Probable is any unexplained less than 30 days of stent implantation, any myocardial infarction, and possible when you have a death which is unexplained by other factors. So this is used in core lab everywhere to define, in CRO everywhere to define, to adjudicate. Here are the contributors in the development of stent thrombosis. There are many, of course, so I will try to give some ones. End-stage renal disease is known, of course, smoking, STEMI, left ventricular ejection fraction less than 40%, non-adherence of to antithrombotic treatment. This is very easy to understand. After that, the lesion, LAD lesion, incomplete endothelialization, instant restenosis, delayed healing, and previous brachytherapy, which was, this is part of the before DES, vein graft stenting. For procedural aspect, DS compared with BMS, more, it has been discussed yesterday already, permanent polymer, DES, and overlapping DES. It is known that overlapping stent is a factor of stent thrombosis. And for post-procedural, discontinuation of antiplatelet treatment, I said that already, and let acquired the stent malapposition that we will show. These are the incidence of stent thrombosis with bare metal stent, first generation DES, second generation DES, and bare metal stent is before DES, and you can see that it was during the first week, went up to 1.5% and remained relatively stable. The problem that was discussed yesterday with Ravel is the first generation DES at the same amount of stent thrombosis during the first week, but a permanent increase of stent thrombosis with time that we can say today that this is probably with this first generation 0.3% a year. And second generation DS seems to have corrected, at least partially, this problem. You can see that the incidence of stent thrombosis is lower than the BMS, and the permanence with the really minimal amount of long-term thrombosis. These are some explanation coming from autopsy. You can see on this slide, bottom right, struts that are not covered, endothelialized, and in front of this immediate thrombus with a thrombus. And at the bottom, you have other struts, bottom right, which are covered by neointima. Second problem is related to acute coronary syndrome when you are implanting a stent which is penetrating the necrotic core of the lesion, which something you see on the right with these cholesterol crystals in the middle on the right, with the penetration in the media and in the intima, sorry, and the penetration of the strut inside this necrotic core. Another situation is stent thrombosis related to medial tear was described by the group. This is the group of René Virmani, and this is, you see on the bottom right, a penetration of a strut inside the media across the EM. And here, something that is probably the most frequent factor is malapposition of stent, which is not apposed on the wall, and which situation which can be related to the procedure or related to late enlargement of the vessels, which is explained here. You see very well with OCT. Massively malapposed stent on the top right, which can be from the procedure or with enlargement of the vessel. So the patient-related factors for stent thrombosis development are male. This is statistical. Left ventricular and diastolic pressures more than 20 mercury millimeter, which normally we don't measure, and previous Timiflow grade 0. These are the outcomes of stent thrombosis. It's a problem. In the mortality at 5 years is between 24 and 39%, cardiac death 14%, and non-cardiac death about 7.5%. And recurrent stent thrombosis is a real problem. It's occurring at 1 year between 11 and 16%, 5 years between 20 and 24%. The variable DAPT as a factor of stent thrombosis is a very complex subject that I'll probably skip. The second problem is stent thrombosis, stent restenosis. Stent restenosis is related to production of neoatherosclerosis, which is said by Park Sun John, a final common pathway of late stent failure. And it existed before the occurrence of DES, but was a phenomenon which was late, beginning after 24 months, and it was coming much earlier with DES, even the first 3 months. Histology, again from St. John Park, showing that the neoatherosclerosis that you can see here on the crown of stent strut, and inside the stent strut, a typical neoatheroma with sometimes with rupture, with cholesterol crystals, and so on. And we can skip also this, saying the same. How to reduce stent thrombosis and stent restenosis? Imaging or angiography guidance. We are discussing that during the case yesterday. Especially, we have to fight against the malapposition. We had recently trials dedicated to comparison of OCT angiography. This Illumen 4, which is a very big trial we discussed yesterday. Absolutely no difference at 24 months in terms of target vessel failure. So there is an explanation which was related to COVID, so it's difficult to understand. But we had more recently, at the same time, we have two trials dedicated to coronary bifurcation. One was initiated not inside the bifurcation club, but certainly by members of bifurcation club. And this is OCT, October, and it's showing at 2 years a reduction of combined incidence of MACE with OCT guidance compared with angiography guidance. And this has been shown by Goran Stankovic already. This is a recommendation done for the operator in the group, for the operators in the group of OCT guidance, 5 complete page, and at the bottom, we have the instruction for the operators performing the angiography guidance. Standard guiding, not a picture, this only work. And, but we have an alternative study coming from Korea, which is still, to my knowledge, not published, but was presented in Amsterdam meeting, European meeting last year, coming from Korea. And with the hypothesis of visual guided PCI remains largely unchanged over 40 years, despite many limitations. We hypothesize that a QCA guided strategy with incorporation of lessons learned from the IVUS studies may help to optimize stent deployment and offset the benefits of IVUS guidance. So they are not doing, they plan not to do an IVUS guidance, but to use information they got to do with angio guidance, especially QCA. And this is the result. This trial is slightly bigger than October, and this is the result at 1 year. And you can see that there is no difference, and even not a trend. So this trial was not completely dedicated to bifurcation, but you can see that there is, first, no difference between any subgroup, and 15% of the lesions were left main, and 65% were coronary bifurcation, non-left main. So what is behind what we have learned from IVUS in order to use better coronary angiography, and especially different kinds of QCA? This is what I try to explain now, was shown already, but this is, on the left, this is a measurement of a phantom, which was produced in plastic, measured with OCT and IVUS. OCT is giving exactly the measurement of the hole, and IVUS is oversizing the surface here by 8%. And on the right, you see that with the OCT being the reference in measurement of diameter, IVUS is oversizing the diameter by 9%, and QCA undersizing the diameter by 5%. So how can we use this information? You measure QCA, better to measure with a dedicated QCA, but you can do with a traditional one, measuring the normal segment, if possible, as far as possible of the bifurcation, but not proximal or distal to another bifurcation. You measure, you add 5% compensation of the undersizing of angiography. After that, you have to take in your, you have to keep in your mind how is working a balloon. Here, a semi-compliant balloon. you have the curve provided by pressure diameter curve provided by the company. And you have to look at the company chart with the diameter you need. You have to look in the company chart, the diameter, which is here, you choose this one, and you have to look what will be the pressure to use. And after that, you know which balloon you will select, at what pressure you will inflate. After that, you have to know that balloons are not only elastic. Of course, the function of a semi-compliant balloon is to be elastic. You increase the pressure, you increase the diameter. But unfortunately, when you increase the second times, there is the same phenomenon. Increase the pressure, increase the diameter, but not the same diameter, a bigger diameter. And if you do a third one, you are even bigger diameter. And you can see here in the clear blue at the bottom that it's difficult to reach the reference diameter, the nominal diameter with the first inflation. So if you have a first inflation, especially if it's short, I will discuss that later, you are not at the diameter you have selected. So you will malappose, for sure. And if you inflate a second time in orange there, you are overlapping the data of the company. So we can consider that this is, you will have the diameter exactly as it was selected and corrected. And if you inflate the third time, your balloon will become bigger, and the difference between each inflation can reach up to 200 or 250 microns. Probably remember that this is part of the definition of malapposition. So this is here the orange curve that will tell you that you will inflate at 8 atmospheres 2 times. In 2013, in my group, was done already before, but by Thomas Vass, one of my young associates, showed that if you inflate 5 seconds at 14 atmospheres, you are not reaching the diameter, it was said, but the diameter is also a function of time. If you do 15 seconds, it will be bigger. If you go up to 25 seconds, again, this will increase by about 200 microns. So long inflation combined with at least a second inflation will give your balloons the diameter you choose. So 2 times inflation at least. When the QCA is corrected is enough. When it's not, you can inflate a third time. Always the same pressure. Don't go to very high pressure. And this is the curve of a non-compliant balloon. And you can see that even in a clear blue here, even at a nominal pressure given by the company, it's very difficult to go over the diameter of the nominal. So it means that you will have to choose not the diameter. If you are not 3.5 but 3.7, to have the diameter of 3.7, you cannot choose a 3.5 balloon. It will never go. You have to choose a 3.75 balloon with under pressure. And you may think that what I showed was produced by Gérard Finet in 2017 in the meeting. But this is old. Maybe this is not true with contemporary balloons. This is an example, 2019, in a very good paper, Skoroworowski, showing that the diameter is increasing with time, and the diameter is also increasing with the number of inflation. What you see is the curve here, the curves you see are relating to times in several inflation, 5, 5, 10, 10, or 5, 5, 10, 20. And the dark point you see just under the curve here is what you will get with a single inflation, whatever the time. So you can see that the difference is huge. So remember, the first inflation of the balloon is not enough, whatever the pressure, the time and the pressure. Stent fracture, quickly. So these are different types of stent fracture. It can help to define which kind of treatment you will do. Also the difficulty, you can imagine when at the bottom here, the 2 pieces are separated, not aligned, and restenosis, and it can be a problem to solve the situation. This is an example, an old one, but it was after 2000 with a flat panel, as you can see. If you look at the PDA, I hope you see well, it's not the case for me. Yeah, you see some aneurysms here. And this is inside the stent. And if you look in detail, okay, we see that the stent is broken. Completely or not, it's difficult to say. Maybe one strut is connecting the two pieces. So what to do in this case, in this situation, was to cross the lesion, which was not so easy, and was even difficult to push a small balloon. You can see that my guiding catheter is deep. And after that, we inflate it as well as possible. And I implanted another stent, new generation, longer, across the stenosis. This is the inflation, and this is the result. So I have to say that we speak now as the frequency of this. Probably, I have not seen recently so many fractures. So maybe this is something of the past. But you have here some data on complications associated with the stent fracture. So the first is restenosis. After that, occlusion. After that, TLR, aneurysm, as it was shown, and definite stent thrombosis. Stent distortion. This is something which was raised especially in the provisional stenting strategy for treatment of left main. And we reported that in TCT long time ago, and at the same time, Akiko Maehara was collecting data from Excel, and so we'll have a mix of this. So this is an example of distal LED, long lesion, distal left main long lesion LED. So I was, as usual, working with just behind my fellow, which is a tradition in our place. So after minimal pre-dilatation, he implanted a stent across the circumflex with wires. Then it was inflated. And then, before even thinking to the OCT, I was just behind him. So I have seen that he was probably afraid by the pressure going slightly down. And he waited not enough time for complete deflation of the balloon. And he pulled the balloon slowly but surely, and the guiding jumped in the left main. So in this situation, when you have a gel wire, the guiding will push the stent. This is exactly what occurred. So you see the tip of the guiding still at the ostium, and you see now the stent, which is 7-8 millimeter more distal. So in this situation, first you have to recognize. I will show you why. In this situation, you have to oppose this strut that overlapping. So you do a pot. And then when you are sure everything is on the wall, you can exchange the wire and do a kiss. And after that, you have to correct, of course, the problem. To correct the problem is to implant a stent proximal to the previous one. If you look at the bottom right, here you see inside the stent, in this stent announcement, these dots, very dark dots, which are overlaps of stent. So the stent was pushed, and normally it was laterally pushed, and you will see, you will understand what I say. And at the top right here, I show you maybe why the guiding catheter is more distal than you think when you are working with it, because the marker is not at the tip. You have some plastic distal to the marker, and this is part of, so you don't understand that you are penetrating too much the left main. When you are working for a left main, whatever the technique, but especially for provisional stenting, your guiding has to be away, a few millimeters outside. That's the first point. The second point, As the guiding is pushing on the gel, on the strut, depending of the gel wire, so the stent is distorted unhomogeneously. So you have a lateral disjunction. So you see the stent is looking at us. It's not normal. And after that, we implanted a second stent and did the proper pressure, many inflations in order to put everything on the wall. Of course, this is not the kind of technique we want to use. Of course, you have a decay crush who can have some overlapping, but in provisional, this is not the rule. And this is the result. And this is a slide issued from a work of Akiko Maehara. It was in Excel. Was found in systematic subgroup of IVUS. So some operators didn't know that they had the distortion. And the mass rate, when you have a distortion recognized, is 13%. No, when you have no distortion, 13.4%, the double for when you have the distortion. The death rate is also not completely significant. A true trend when you are speaking about cardiac death, left main related MI is of course much higher when you have distortion. Left main ischemia driven TLR and even stent thrombosis, a trend because the population is not enormous, but you can see that there is a real trend. So my conclusion on this different mode of stent failure is not all complications are related to drugs and material. Many are related to absence of knowledge of their use, the drugs, the materials. Sometimes good instruments are abandoned following improper usage. I've seen that in my career. And it was a pity, but when there are accidents, they have to remove. Knowledge of the instruments and proper usage help you to perform successfully more complex procedure. That's why I explain how I'm playing with pressure, time, and selection of diameter. Strategies have to be compared fairly, which was, in my opinion, not the case in the October trial. Thank you, and others. Thank you very much. This is for those of you who never heard about how to manage with diameters, multiple inflation, and pressure. You think that it was on the slides by Gérard Finet in 2017. This is a list of papers you can read if you want to take a photo. You will see you have a lot of lectures. The last one, Amstut and Skowronski, are very beautiful papers, very interesting.
Thank you so much. Thank you so much for your lecture. I have just a comment, a question, I don't know. I completely agree with you about the October result, the October trial result, even because if you look to the table inside the paper, you realize that, I mean, for years we speak about the utility, the usefulness of OCT in bifurcation. If you look to the table in bifurcation, angio-guided is slightly similar or even better than OCT guidance. So it's the opposite of what we normally presume using an OCT. And explanation they give an explanation. I'm not convinced too much, but anyway, that is. Another point is on the utility of angio-guided is, all the steps you mentioned. And also, I think we have to think about when we size the stent angio-guided, we have to use the Finet law. And in my lab, I put a chart before the operators, and when we put the number, the diameter on a visual estimation of QCA of LAD and circ, and we have the left main diameter using the Finet law. We published a couple of years ago on angio-guided with the Finet law evaluation, and is pretty good and very similar to IVO's guidance about the result. Another thing is, don't you think that probably with the third generation stent, the problem of stent, the crimping is a sort of stent failure? We published a couple of years ago in American Journal of Cardiology differences in stent crimping using first generation, second generation, third generation stent, and we saw that with the last generation stent crimping is pretty more frequent, still rare, but pretty more frequent than with the other generation stent.
What I'm sure is that cannot be worse than what we have when we were manually crimping in the early 19th. But, you know, this is typically the kind of thing you see if you practice, you know. So I'm off the cath lab since a few years, so these technical data, which, you know, we all dream that we'll put a paper in Lancet. Of course, this is not for this. But what is important for all the operators is to understand these little things, you know, and to see that some problem can be solved as technically. So yeah, I don't know, but it's possible. You know? It's possible because they are thinner and it's probably more difficult to crimp. Yeah.
Yeah, the good thing is that are more easily catchable with the snare, and also if you cannot snare, you can even park on the side of the wall because are very thin. So
yeah, we did that with big ones, so it was not good. So I just forgot the point is the stent enhancement. I asked for it yesterday, but okay, it was not done. The stent enhancement has its reference by Gary Mintz and Akiko Maera, telling that the measurement of stent enhancements are coherent with the IVOS measurement.
Yeah, sure.
There is a reference, a paper with a reference for this. So if you look, you will find.
Any other comment?
No.
Okay. Just a comment about the October. If you look at the results of October, and you have to say that for your patient, okay, now we have to use OCT to guide your intervention. And the patient asks, what that will improve? Did I live longer, more? No. Did I have less TLR? No. Did I have less MIs? No. And because the October is positive trial only in one point, the MACEs. When you catch all the small numerical differences from MIs, TLRs, and all the points, and then you have even the p-value is not so less than, it is less than 0.5, but 0.05, but it is not so much. And the truth is that nowadays, angio-guided PCI of bifurcations is not what it was, let's say, 10 years ago. Because now most operators at least operators who were involved in the October trial, they know Finello, they know about the pot, they know how to do kissing. And this much more improves. And the improvement given by imaging practically is so small that you cannot catch it into individual points of all the different MACEs. And practically, for me at least, October did not change anything.
Maybe that
guided, if you follow all the principles which you've just pointed out, which are, I think, the most important points. Because these are principles which should be followed really as a laws.
May I add a point to be clear with the audience? You know, why I'm speaking about the guidance without OCT. In Europe, 5% of OCT maximum, OCT and IVOS together, 5%. So, you know, if you are in a meeting to speak that this is absolutely necessary, we cannot avoid to use that. The people who are speaking that, they are not honest. in Europe. In other countries, like in China, they have a very high rate. In Japan, they have something different. But OCT, I like much more OCT compared with IVUS. IVUS, I'm unable to read that, so that's because I'm not trained for that. But we learn so many aspects of bifurcation with OCT that it is certainly a very important way to acquire the information. You know, penetration of distal, this kind of trial, distal penetration, proximal penetration, can be done only with OCT. It's impossible to do everything. Well, I was disappointed in OCT that it was no recommendation for angio guidance. For me, this is not fair. So if we have to redo it, the Korean did, but if we have to redo it, we can recommend some of the things I recommended, and we'll see the end. Because I'm still thinking that there are maybe some aspects that we will have from OCT with an influence on the results that we don't know. What we do with angio guidance, we do a complete apposition, we do a good sizing, we avoid insufficient expansion. We can do that without OCT, I'm convinced. But maybe there are some factors on the nature of the material in the world which have an influence on the future. So, but they have to, what I was waiting of OCT was this.
Maybe in the matter of time later. Yesterday, when one was performing relatively simple complication, you said, let's do it, and I will tell you how I'll do it without the IVUS. What's my question? You can perform the thousands and thousands of complex interventions and be a second advisor for 1,000 the others. Is there a learning curve with imaging that you know what will I see? What do you think about it? You perform, let's say, 100, 200, and then say, I will start with our imaging and I will use it only when it's needed. Do you have this? What is the percentage of imaging used in your cath lab when you go to the complex lesion?
In Massy, even today, was less than 5% when I was working, and I'm completely sure this is the same. What we have done in Massy, I remember, for when new associates came, after the fourth one, and we asked them to do left main with imaging for the first 50 cases, which is enormous, you know. How long time you will take to do 50 left main? For some operator, will be 10 years. So we asked the newcomers to do imaging. They did imaging, and this is probably the part of 5%. They do imaging for when they are not experienced in a new technique. So we do imaging, and we learn from imaging. And after that, after we have learned, then you can try to do without. This is exactly what the Korean proposed.
If you allow me, in Poland, where the IVUS and FFR are reimbursed, yes, and they have complete reimbursement for imaging. And despite that, they have, I think this is the highest percentage penetration of IVUS guidance of procedures. They have around 13 or 14% of all procedures. Despite that, the IVUS and OCT are reimbursed. They don't have financial limitation of that. This is what I...
Why?
Why?
Because
Legutko now he's making a trial. Why? Because despite that they have this on board.
Maybe we have an opinion of Ravi, how he is doing in US. 100% of IVUS, 100% of OCT.
It depends on the location of the lesion. I would say left main, for example, high penetration of IVUS, acute coronary syndrome, high penetration of OCT, proximal right, proximal LAD, high penetration of IVUS.
What is high penetration? 100%? 50%?
No. I was going to come to that, 25-30%. Stent failures, mostly OCT and some IVUS, very high, 60-70% if we can get the device down, because imaging stent failures is important, so you know how to treat them.
Yeah, I agree.
If it is under deployment, undersized, then you can do the right balloon. If it is proliferation of smooth muscles, then you can do debulking and put another stent. If it is thrombus, you can clear the thrombus. So total penetration, I would say, is 25-30%, mostly in the cases that I mentioned. So if we don't do it, there's a lot of criticism. We have a lot of fellows who are trained, and they say, why are you not doing IVUS? So when I do a case, I'm very often saying the lessons I've learned from IVUS, I'm going to translate to angiography, and I know what to do.
Yeah.
So they say, no, you have to do IVUS. So I say, okay,
So-
go ahead, put the IVUS in.
Don't you think that the more important thing we can wait from this kind of trial is to define the situation where it is useful? So subgroup and the population where it is not useful.
Right.
So here we have, okay, OCT is better, so we have to do OCT.
Right.
Which is a message, first, this is wrong, and first, we know is economically not feasible.
Okay, thank you so much. Let's move further with our biggest fear, stent thrombosis, and the talk delivered by Dr. Rigatelli.
Yeah, thank you. It's not a repetition of what Eve stated very clearly. It's just, I will try very shortly to give you another, some different point of view. And this is the day I arrived in the new hospital. My senior assistant did this bifurcation CTO with a very nice result. I was in the administration to sign the contract with the new hospital, and I was on call in the afternoon and evening after 6 hours. That was the result. So something happened, and just to, this is a very nice, a very nice picture that is never been shown before here, at least, and is from Journal of Society of Cardiographic Intervention in 2023, and it gives a look on the last 20 years of stent. In blue is stent restenosis, in orange is stent thrombosis, and in gray, a very late stent thrombosis. You see that from the BMS era to the second generation DS and the last imaging-gated DS implantation, there is a clear decrease in restenosis rate, but I mean a slightly increase in a very late stent thrombosis. Obviously, stent thrombosis is a complex phenomenon that, as Eve say, different substrates, and at the end of the day, in the early DS era, we have 3.5%. In the new DS era, we have 1% stent thrombosis rate. What is the new generation stent? This is the same, basically the same slide of Eve. Continue to maintain after years almost the same rate on stent restenosis. And if we look to the years from the randomization, this continuing curve reach for the new DS up to 10 years rate of 0.2 rate of definite stent thrombosis. If you look again to the comparison between early generation, new generation, with a couple of major estimates, you can see that the new generation have a clear increase in the temporal pattern of in-stent thrombosis, while the early generation was still high at up to 10 years. Obviously, the rate of in-stent thrombosis depends also by the presentation of patient. So patient presenting with acute coronary syndrome had the higher incidence of stent thrombosis than those presenting with stable ischemic heart disease. And the patient presenting with myocardial infarction, in particular ST elevation, STEMI, had the highest incidence of stent thrombosis. So something that depends also on the presentation. And if we look to the different presentation, again, we have that within the first 30 days post-PCI, a patient with the STEMI had a higher risk of stent thrombosis than patient with unstable angina, and or then patient presenting with stable ischemic heart disease. So within the first 30-day presentation matters. Beyond the 30 days, there was no significant difference between the clinical presentation. Is another thing to keep in mind when dealing with our patient. And this is also obviously related to the platter reactivity. And if you look, that is different under different clinical presentation. So patient with high platter reactivity, STEMI patient had a higher risk again than patient with unstable angina, and a patient with a non-acute coronary syndrome, because they have the lowest 30-day risk of stent thrombosis. Beyond this term, 30 days, again, at least in patients with high platter reactivity, there is no clinical difference. So we have to keep in mind that there is presentation, different clinical presentation has different platter reactivity, and within the group, the most the window where these different are more evident is the 30 days term. Just to concluding, we can postpone the discussion after the second one, so we gain some time. So early stent thrombosis has decreased over the past 10 years, but late and very late stent thrombosis, on the contrary, has slightly increased. Stent risk is different in clinical, different presentation, and depends also on platter reactivity. Thus, platter reactivity should be tested as possible in any patient, in particular in patients with the most severe clinical presentation like in STEMI. Imaging-guided PCI has the potential to reduce the impact or risk on stent thrombosis, but if, as we discussed with Eve, probably depends on the the technical skill and on what we have learned from the imaging era in our training. Give me the second set. Yeah. Yeah, instant restenosis, to me, is not too much a different behavioral situation, because, in my opinion, is the same slide before, because it includes both instant restenosis and instant thrombosis. Here's the different phase of a similar phenomenon to instant thrombosis. In my opinion, it depends on on a number of different features, but at the end of the day, we have to realize that there is something more than stent bioengineering, materials, polymer, and so on. It is also a matter of local vascular environment, local vascular flow patterns before and after stenting. Sorry. This is a STEMI patient with a previous ostial 90% calcified disease. Shock wave was done with 8 cycles of 10 impulses. Then we put Cyan 3O. He had the first restenosis and STEMI, very complex to deal with the restenosis. And no imaging at that time, so DCB prevail balloon 3.0. This is the second STEMI restenosis presentation, and we were at the same point of the start of the story of this patient. Instant restenosis has got some obviously factors at multi-level, stent factors, and HIV give us very clearly which are the stent factors involved, under suspension, the sizing, fracture, whatever. Some instant factors that are the amount of neo-intima hyperplasia, neotherosclerosis, that in my opinion is not, we shouldn't categorize as instant restenosis. I mean, in my opinion, neotherosclerosis is another animals. Calcification, type of tissue, local, diffuse pattern, obstruction, severity, whatever. And some extra stent factors, multiple stent layers, vessel calcification, calcified nodule, vessel size, residual plaque burden. But there is a role for rheology. Is it only a matter of stent-vessel interaction, or is also a matter of rheology, vascular, local rheology? When we put a stent inside a vessel, we disrupt the usual physiology pattern of flow. It means that from a fluidodynamic point of view, we disrupt usually the physiology of the vessel. Rheology and Walsh stress forces impact on the probability of restenosis and also stent thrombosis. This is an old study on the right, sorry, where we evaluated the potential substrate of restenosis and thrombosis in overlapped BVS. And we clearly demonstrated then not only the stent strat give an impact on rheology and amount of Walsh stress forces, but also the implantation technique. So when we put a stent, whatever the stent is, BVS, no BVS, whatever, we change the local environment of the vessel. So usually we lower wall-shear stress forces in some part of the vessel and we increase wall-shear stress forces in another part of the vessel. Both are not good. I mean, lower wall-shear stress means restenosis and thrombosis. Higher wall-shear stress forces, again, are involved in restenosis and thrombosis again. So the physiology is to have the wall-shear stress forces at a certain amount and a certain value. If we go lower and higher, we disrupt the vessel physiology. And also the impact of our technique is very important because this is on the left. There is a very recent study. We use a computational flow dynamic to calculate the residence time of the blood flow in complex limb bifurcation after stenting. And here is a complex bifurcation. So it's an OCT-derived study. So we perform a real patient, crossover, decay crash, nano-inverted T technique, and we calculate, we segmented the OCT imaging and we calculated the residence time, wall-shear stress forces, pressure, hydrostatic pressure, and so on. And what we have is that in provisional, when you use a provisional in complex bifurcation, the residence time is much higher than we use decay crash, and practically there is no residence time when we use nano-inverted T. That is very physiologically compared to decay crash or cool-out technique when we use in complex bifurcation. So it's not only matter of stent engineering, polymer, pressure, whatever. It's also matter of the rheology of the vascular bed, of the segment, that is different in different people, and is also matter of how we change the flow with our technique of implantation. The pathophysiology of restenosis is different, obviously, DS from BVS. Here, I don't know to bore you with all these features that are derived from OCT that is useful to understand the pattern of neointimal proliferation and the difference between neointimal proliferation on the left and neotherosclerosis on the right. And again, I'm not convinced that neotherosclerosis is a form of stent restenosis. It's a different matter, it's different animals, is what happened to the vessel after stenting on the long term. And if the stent is well done, probably the vessel is, is still prone to atherosclerosis. Because if the stent is not well implanted, probably we saw in-stent restenosis or thrombosis. So it is a sort of healing process that predisposes again to atherosclerosis if we not curing the risk factors. The clinical outcomes of different techniques are different. Obviously, this is a very nice review in literature and of all the in-stent restenosis trial. And you see here that we have intravascular brachytherapy, rotational thoracotomy, drug-eluting stent trials. I remember you that drug-eluting stent for in-stent restenosis is class 1E. And about drug coating balloon trials, and we saw here the clinical outcome. So which is the preferred strategy? One thing we learn is that when we treat in-stent restenosis, the aim is to maximize acute gain and minimize late loss. And the most important parameter when comparing DS and DCB for the treatment is, of stent restenosis is the net gain. So going to the practical point in the last two slides, you should identify the pattern of the stent restenosis. So here, probably performing an intravascular imaging is a good option. You cannot rely only on angiography, probably, in the situation. If there is a mechanical issue or not, if there is no mechanical issue, you should perform routine predilation. If there is mechanical issue, you go to resolve this mechanical issue, and then try to identify the treatment for the underlying stent type. So if it is BMS, DCB or DS probably have comparable efficacy. If you don't know stent type, which is DS or DCB, DS probably are moderately more effective. And if it is DS in stent restenosis, again, DS have got some kind of prevalence, but the DCB treatment is gaining much respect now than in the past because of new balloon and new technique of applying the drug on the surface of balloon. So at the end of the day, you can do and you cannot do something, and you have a certain list on the right of the slide. You have to define instant lesion. You have to identify contributory factors. You have to address mechanical issues and treat as per underlying stent type. So going back to our patient, we have a second restenosis and STEMI. We try to pass with a small balloon, very high pressure. Then after gaining some space, we do a stent boost, and we saw that on the part of the stent, in the inferior part of the stent, there is something not clear. It seems like one or two strata are not aligning with the other. Here we put suspect a fracture, but probably it's not a fracture. We put an IVUS, and we saw something not good on the surface of the stent, like one or two strata again not aligned. So we cover with a DS different drug, a Synergy 3.5 dilated, and this is the final result, and you see that at the IVUS is very okay, the result is okay, and the cross-sectional area is good. So, in conclusion, instant restenosis is a multifactorial phenomenon, should be understood before treated, so it's a good place here for imaging. Treatment algorithm should be tailored upon suggested mechanism, and a clinical trial gave some light about the ideal treatment, but therapy should still be personalized. Thank you so much.
Thank you so much for your talks. Do you have any questions from the audience? From the floor? I have one comment or question. Because we saw that in the majority of the cases, the reason for a stent failure is technique or operator dependent. Do you think that it's the right time to have a guidelines how to implant stents, to go a step back and to know how to implant? What I mean, in the past, when the absorb stent was available, we had simple rules how to implant the stents. Do you think that it's the right time to have such recommendations general?
I think that is the right, I mean, it's not yet the right time, but we have to think to what we do when we plant a stent in respect of the vascular bed. And for so long time, it's 50 years that we implant stent, not me itself, but everybody. And we only look to pressure, type of stent, material, matrix, whatever. It's time to think that what we do in respect of the vascular bed is disrupting all the physiology of the vessel. We have to think how to manage the procedure in order to have more physiological flow. Because it is a matter of flow, not only of stent material, whatever. Is what we do when we put the stent to destroy the physiology. We have to regain a physiological pattern. And now, how many people got QFR in their lab? Do you use QFR? No. QFR has the same principles of computational fluid dynamic. In my opinion, we are ready in the future 5 years to have computational fluid dynamic online with the QFR software, and we will be able to calculate not only the QFR before stenting and after stenting, but also to calculate the wall shear stress forces before and after stenting. So we will have the way to correct too much lower and too much higher wall shear stress just online during the work. We tried 3 or 4 years ago to calculate the cutoff of wall shear stress forces in not critical left main to predict occlusion of the left main. We did offline, but I'm sure that in the next 5 years we will be able to do online, and there will be another way to work, I think. Thank you.
Yes, the biggest. Just to comment, the biggest problem with the QFR is at the moment this is the price, because actually the price of one license or one examination is the same like FFR wire. So despite that, QFR gives some much more possibilities just to calculate the flow velocity and so on. So really much more possibilities are available. But regarding the stent thrombosis, there are unfortunately a lot of items which interplay. We had a patient around 2 weeks ago, the old lady with a very, very long diffuse LAD. And this lady, I made a distal angioplasty with a drug-coated balloon. The whole segment was around 5 centimeters, and proximally I implanted the drug-eluting stent 35 millimeters. This lady was, because it was acute coronary syndrome, this lady was left on ticagrelor. I made a stent poof, pot poof, like if likes this maneuver, but I use it I didn't know that it could be published, but I use it for stent optimization without IVUS for a long time, not only for bifurcations, just to be sure that my stent is well opposed. And I left the lady. On the second day, the lady had a massive hemorrhage from the large intestine. And the lady went to gastroenterology. The colleagues stopped on the day, actually 48 hours after the procedure, they stopped the antiplatelet therapy everything. And they made a colonoscopy, and there was a tumor formation, bleeding 5 centimeters in the large intestine. And that that happened without our knowledge. And on the day 9, gastroenterologist came to me and asked, what have we do with antithrombotics? And I said, why? He said, because we stopped them. And I said, and the lady is alive? He said, oh yes, she's pretty well. We made the 2 blood transfusions, but she's okay. And we saw and the patient was absolutely okay without any antithrombotic therapy 9 days after this intervention on around 8 centimeters of LAD. And this is the importance of rheology. And if you, in 1995, Antonio Colombo clearly demonstrated that you can make even PCI at that time without heparin, probably if Gianluca for sure remember this article in circulation. It was very debatable at that time. I was still a student because 1995 was the year when I decided to be a cardiologist. And just the importance of rheology, the importance of flow dynamics is crucial, at least for me. And the problem with the stent thrombosis, just to summarize, the problem with the stent thrombosis is, at least for me, maybe 90% of procedure-related factors are the most important. Because if you implant your stent, if you ensure the laminar flow into the vessel, there is a 99% probability that nothing will happen with this vessel.
Yeah, for sure. You decrease the residence time.
Exactly.
That's the explanation.
This is what actually Gianluca last year's worked a lot with flow dynamics, and practically from all these studies, maybe we can summarize as a conclusion in one sentence that the flow dynamics and the shear stresses are the most important at the end of the PCI, but we still do not have how to, during the PCI to calculate it, just to know how to finish in optimal, from flow dynamic point of view, way of PCI.
Excellent comment. Thank you. We'll move further with something really interesting in my mind, the talk of DAT, and it's going to be about the drug-coated balloons used in coronary bifurcations. The floor is yours.
Dear moderators and panelists, esteemed colleagues, it's a pleasure to be here. I want to thank Valerie Dombrin to give me opportunity to talk about topic drug-coating balloons in coronary bifurcations. Please take a moment and think about your emotions when you see complex bifurcation lesions. For me, they are beautiful and brilliant and inspiring and unique. If do you think so? Yes, and this is the representation of womanhood. And because of that, I think that we should approach to coronary bifurcation lesion with respect it commands. And our touch must be careful. As we honor the complexity, elegance, contrast, and harmony, each intervention in bifurcation presents a world of opportunities, challenges, and an unparalleled spender. I could say it because I'm a retired cardiologist. Yes. The treatment of bifurcations is still, in some way, an art form. one of the greatest minds in interventional cardiology. And I think, yes, the intervention on bifurcation is a place where the science meets the art. You will need knowledge, expertise, clinical judgment, technical mastery, and clear vision and instinct, but only with a passion and creativeness you can make your work as a true art form. And what about the DEB, honestly, DCB? Even after 2 decades, they are not routinely widespread. With a mere of 6% of penetration in our everyday work. Why is that? And where do you see you in this spectrum of intervention cardiology? Is there anybody in the room that is skeptic, doesn't believe in this technology completely? Or are there any enthusiastic adopters, champions of DCB that will do the predilatation, try to finish the intervention without the stent? So that's the reason why you invited me. But the rest of us, we use the DCB when we think that the stent is not the best choice. How do we decide? Anatomically, probably. The length, the diameter, the tortuosity, the calcification, and the place. But what is most interesting for me are these bifurcations, true bifurcations with physiologically, anatomically, clinically important side branch. When do we move to do something new? And what is the place of a DCB in these lesions? That's what is interesting me. We'll talk about rationale of DCB use in bifurcations in the next 15 minutes. What are the data in the literature at the moment? What have we done in European Bifurcation Club to move forward with this type of intervention? Some technical considerations and conclusions, of course. From its beginning, you will completely agree. The philosophy of European Bifurcation Club is keep it short, simple, and safe. Even for the complex lesion, start with a stepwise provisional approach, add the layers of complexity as necessary, and put the second stent only when it's needed. So it's very attractive, intriguing to think about DCB use in bifurcation because we could put a high level of homogeneous application of the antiprolactive drug to the bifurcation area when it's very important to cover every single millimeter. And we will, what is this? Sorry. It doesn't work.
Use the mouse.
And we could avoid the stent and the use and avoid all what Yves and Gianluca told us about complications of the stent and keep it short and simple. If it's successful, we could do no wiring, rewiring, deprivation of the stent by kissing balloon, and so on. I will try to be short about the data. If anybody is interested, I will give the data from this book that we published. We will skip the bare metal stent part. It's obsolete now. But here it's very interesting. Two retrospective studies, about 300 patients that compared conventional balloon and drug coating balloon. And you can see it's not working, the pointer. First, no. Here? What? It's not working, okay. But you can see that clinically and geographic outcomes are 2 to 3 times less with DCB compared to POBA. There are 3 observational studies, prospective, and 2 retrospective studies comparing DCB and DES. DCB in side branch, and 2 last one retrospective with a huge number of patients, 2 stent techniques and DCB in side branch. And again, DCB have 2 to 3 times better results than 2 stent techniques. Even the mouse is not working. I don't know what's that. Now this is the pointer.
This hold it down.
And
You need to show there.
okay, and this, and to go.
This is to go next year.
to the next. So we can say that again, it's not working. Now it is. I don't know. All of these studies are clearly of small size, only 4 randomized. There is high level of heterogeneity regarding the treatment strategies, the phase of the procedure when we use the DCB, time and complexity of bifurcation lasers. Always, most of them, the precise description of lesion is missing, and of course we can surrogate endpoints, and they all use paclitax cells. But we can say that the use of DCB is effective when deployed in side branch, and even aggressive only DCB strategy is feasible and safe. Thanks to Yves, after one of these meetings, we organized the first session of DCB in Bifurcation Club in Barcelona, and one finished it with presenting 4 possible scenarios for future clinical trials. At the same meeting, we have a separate meeting analyzing the online survey participated by more than 100 ABC members about what is the future of the trial, how to design it, and publish the paper later. In Bristol, again, led by Chevalier, in front of Cardiovascular European Research Center, we discussed the possible studies. It passed 1 year later, and 4 of us presented our ideas, what will be the study, what will be best design study. And last year, there are 2 important presentations. One was with the Chen, and another by David Hildy-Smith about protocol ABC, DCB trial. So it will be done, probably. I will briefly say what the Chen have proposed. It's ongoing study of about almost 800 patients with true bifurcation lesions with a side branch less than shorter than lesions shorter than 10 millimeters, but the diameter more than 2.5 millimeters. They will be randomized in 2 groups, comparing non-compliant balloon and DCB superiority design. You see that DCB is implanted after dilatation of the side branch, and then the final kissing will be done. I'll try to ask the Eve what is the future of ABC-DCB trial later. We discussed it last night. And Dr. Cortese supports my idea about Pro-David study. Maybe we'll publish it, maybe we will stop. It depends of ABC. But I'm thinking that if we design the studies, the strict inclusion criteria must be defined. What type of bifurcations, lesions do we want to treat? Clear flowchart for predilatation. We must predilatate the lesion by the flowchart. Clear criteria for bailout. We should compare DCB to the best-in-class DES with high clinical endpoints and follow the patients at least 5 years. Some technical details of my personal perspective. The predilatation, we are talking about true bifurcation lesions. Predilatation should be separately done in main and side branch. There is opinion, of course, try with semi-compliant balloon, try to reach the 1-to-1 ratio, balloon-vessel ratio. And if it's difficult to put the balloon, try with a smaller one. And Dr. Bursota proposed something logical approach, never accepted, I think, by the European Bifurcation Club, by simultaneous inflation, kissing inflation, wide undersized balloon. It may be logical to make the carina or something like that. Personally, I don't use it very much. If there's any calcification or is there no expansion of the balloon, go to the cutting, scoring balloons, non-compliant balloons, of course, first. If any calcification, start with it, and then use prolonged inflation or advanced methods for calcium. It's very important to define the successful predilatation. This is the minimum. Fully inflated balloon of the correct size, less than 30% of residual stenosis, TIMI flow free, in no flow limiting dissection. I didn't put the physiology in these guidelines because in Asia Pacific guidelines they put it, but it's very liberally to use it if you are not certain. And if no, put a stent. If yes, you are successful, you have the successful predilatation, then you can think about two ways. One is for enthusiasts only. 2 balloons, in main and inside branch. Sequentially, never kissing balloon with the drug coating balloons. You don't want to lose the drug, pushing the 2 balloons simultaneously. And be aware of geographic mismatch. Personally, even for smaller lesions, but in any way with a complex lesion with a left main and LID with a significant side branch, maybe with the definition chain definition criteria, I propose this so-called provisional DCB approach. It's something like this: predilate main, then side branch, wait for 5 to 10 minutes, give the nitro, eliminate acute recoil, and then if yes, just put the desired DCB for, if you can, 60 seconds in side branch, put the stent in a main vessel, do the pot, check if there's a satisfactory result, go out without kissing, keep it short and simple. So I think that DCB use in coronary bifurcation lesion setting is one of the most attractive, emerging indications of this technology. There are a lot of questions to be answered about technology, techniques, the time of application, and so on. And I think that in future we should be concentrated to investigate these two ways: DCB only, or main branch stenting and DCB application in side branch. This could be potentially, when you don't want the stent in main branch, maybe this pro-David, let's say, way is way to go. And of course, we need a future well-designed randomized trial to prove, to move the frontiers of this question. Thank you.
Thank you very much for your excellent talk. Do you have any questions from the audience? Panel?
Excellent talk. I was looking at your last slides. So you recommend to include side branches more than 10 millimeter lesion. I agree with you. As you know, and of clinical importance, only 20% of side branches in coronary arteries. So maybe it will be difficult to recruit this, to have this population. And I was thinking about the result is not published, but we had a preview from David for the 3 years of EBC main. What's very clearly there is an advantage of provisional in the left main, provisional in lesion less than 10 millimeter, and a probable advantage of stenting for more than 10. So I imagine that if you adapt, if we take your design, but on the left main with a lesion longer than 10 millimeter, it will be DCB versus DES. Yes. I think this one for me is my preferred protocol. So I don't know exactly what David is in charge. David Hilding-Smith is in charge of discussing with companies. There is a sponsor, but you can imagine, I think you can imagine what will be for a sponsor takes the decision to use DCB in left main treatment. So I don't know what recently I discussed with him. He was back to non-left main. So back to your idea with long lesion. Personally, it will be difficult and probably clinically not as relevant as the treatment of left main. So I hope he will.
During these 5 years, we have a lot of emails and
yeah, it's difficult. Huh? We are on this since
and changing the
2019.
Mind.
Yeah, you know, and even 3 months ago, David was in favor of stent versus DCB in left main. So all DCB, no stent at all. So this one, probably the company said no. I have another question or discussion is, I was speaking this morning of how to inflate and repeat to get a diameter, which is on the box of your balloon. What to do with DCB? We do a single inflation. We cannot do a second inflation. Yes.
Maybe you will remember when we got the top guys from the DCB world in European Bifurcation Club. Cortese, Scheller. And DCB guys are very strict when to use the DCB and how. They are thinking about DCB. European Bifurcation Club is thinking about bifurcation. And I try to be in the middle to find a way how to make it. They think you should use the balloon before you do anything. It's only to deliver the drug. You should prepare the lesion completely. And you should do it before putting the stent. Before. Why is that important? Then we come back, what are the inclusion criteria? I'm thinking if you have a complex lesion, the only dilemma is whether upfront use of 2 stents. We don't want it in the European Bifurcation Club. We want to keep it short and simple. If you want to keep it short and simple, I don't want to use final kissing. In our latest recommendations, there is one sentence. There are no clinical proof that you should routinely do final kissing. That's for the first time in last, So if you routinely don't do it, and you don't want to push your DCB across the struts to lose the drug to a then start with the side branch. Prepare it aggressively if you need.
Okay, but
Have a result and finish it simply.
let me say exactly what is my question. You have the answer. I hope you have the answer. The side branch is 325. So
yes,
you take a DCB 30. You inflate at the nominal pressure 325 one times. The balloon is the one we use for stent, we use for predilatation. It's the same kind of balloon. So the balloon will not go at the first inflation, will not go at 3.25. It's too small. So do we think that in this situation, when you have to be on the wall at the first inflation, may have to choose a bigger balloon at lower pressure? So this is the kind of thing we have to discuss before for the protocol.
okay.
Because if you don't do that, we won't put drug on the wall. And as you say, we cannot go back to do a kissing inside. Do you kiss in a lesion treated with DCB? No, because you will destroy the cut.
Chen, in his trial, is routinely, in his protocol, is final kissing after delivering, after the drug. For me, that's nonsense. Why should he do it? Maybe
we'll have the results soon, huh? It will be presented at
800 patients in China to prove superiority of DCB in bifurcations. Why he didn't do it in a native lash of 3 millimeters? Why to do it in bifurcation?
In fact, what we have done in
we need a combination of protocol trial and device trial. We have to integrate simplicity and potential of DCB in one trial. So the technique must be precisely defined, definition of the lesions must be very, very precise. And I think it must be definition criteria. Complex lesion with significant branch. Everything else you can do whatever technique you want. But this, we don't know the answer. If it is non-inferiority, this approach, if it is non-inferiority, every complex lesion we can do this by the simple way to start provisional DCB and finish it with the second stent when it's needed. We don't change the philosophy of European Bifurcation Club. We open the door to make the new way of approaching complex lesion with simple way, by new technology and accepting aggressive predilatation of a side branch. And in the European Bifurcation Club, for the years, don't touch the side branch. But even in AVC, it was touched for 47% of patients. out of the protocol. And ABC main, only 19% of patients had the definition criteria of 400 patients. So we couldn't compare ABC and double kissing crash cry.
Just comment first regarding the left main and DCBs. The problem with the left main is that the left main have a different structure at different points. At osteo midshaft, this is a continuation of the aorta. There is almost no muscle tissue there. It is on the distal, and I think that with the current medicines which we use, which are cytotoxic but mainly for the muscle tissue, it will be difficult to obtain any good result in the left main. Even if we left behind the spasm, recoil, and so on, just because of the medicine, we cannot achieve more. Just we want to there are limitations also, not only from the recoil, dissection, and so on, but delivery of the drug. And this is why I think that everything is possible in this life probably, but it is very low probability to design and to perform with a good result the DCB trial for the left main. The second point is I'm one of the biggest users of the DCBs in Bulgaria. Even we now yes, I know Nikki, but probably you're the second one. And we now almost finished recruitment of the patients with the diffuse disease treated only with DCBs. We sent an abstract with the preliminary results for the Euro PCR, and for the European Congress of Cardiology we will be ready with the whole population and initial follow-up. And from these results I can say that DCBs are really, really effective, and we have to change our minds. This is the problem at the moment, even for the bifurcation, what they said. The problem for the treatment of bifurcation is that our mind is strictly attached to stents. At the moment, we cannot imagine at the moment, this is the truth, that bifurcation could be treated well only with the balloon, and just we have to go back from where probably this is a spiral, if it's smiling, because actually this is returns from where everything started. And probably this initial point was the right point. I mean, but now with the different devices. Now we have much more sophisticated devices with much better results. This is a comment.
It's time to, yeah. Thank you so much.